Good afternoon, everybody. Thank you so much for joining us for this webinar around the co-design of the Safe Space Hub in Redcliffe. It's great to have you with us. My name's Bronwyn Edwards. I'm the CEO of Roses in the Ocean and part of the co-design facilitation team. And with me is James.
Hello. One of the facilitators as well. Thanks, Bron.
Terrific. So look, we're just going to share our screen and we'll take you through the slides for today. There we go. Okay. So first of all, we'd like to acknowledge the traditional owners of the land on which we're meeting today, here in Brisbane, the Turrbal and Jagera people, and pay our respects to ancestors and elders past, present and emerging. We'd also like to acknowledge all people with a lived experience of suicide, particularly those who have been involved in this co-design process and those within the catchment area and the surrounding suburbs of the Redcliffe Hospital as well, for whom we are working together to create this safe space hub. In terms of where we are in the process, just to give you some context, you'll see that we've run lived experience focus groups, so small groups of 3 or 4 participants. We then brought all of those people with lived experience together into a group session here, and after those 2 phases of the co-design process, we went into feedback loop number 1. In parallel with that process, we also met with small groups of health professionals and other stakeholders, and feedback loop 2 then followed those conversations. From those 2 feedback loops, we collated all of the information that had been shared, and that fed into a group session with health professionals and other stakeholders. And then this feedback now, which is known as feedback loop number 2, is now providing an opportunity for us to share with you where we are in the process following all of those different touch points, including that group session with the health professionals. Now, accompanying today's webinar will be a survey, and we really want everyone who's been involved in the process so far to go through that survey. It's your opportunity to sense check what we've heard, that we're actually capturing everything that you're saying, that we've got it right, and to share that as broadly as you can amongst your own networks of people with lived experience of suicide as well as health professionals, such that we can have more people in the community contributing to the overall process too. All right, so to make a start, first of all, we're looking at the needs and ideas with regards to location. So the ideas of how to meet the needs that people with lived experience have raised in terms of location. The needs were spoken about in those small focus group sessions, but much more deeply in the group session where we encourage that blue sky dreaming that's so important, that we capture the ultimate way to meet the needs of people with lived experience in this new service. Obviously, we know that not everything will be possible in this first round of funding and what have you, but it was important to capture all of that. And then in that group health professional session, we were able to share all of the insights that had come from people with lived experience of suicide and have the health professionals to contribute to those discussions also. So we use a traffic light system in this part of the co-design. Anything that you see in green means that there's really good alignment between people with lived experience of suicide, health professionals, other stakeholders. If it's orange, it means there's room for conversation and we need to have some more discussions. Definitely would like some more input through the survey on these particular areas as well. And there's not any red in this instance, but if there is a red, it means that something is completely out of scope for the particular project. All right, so in terms of location, one of the significant needs that was highlighted was physical safety, but we had a lot more opportunity to talk about location in that group session where we did the blue sky dreaming. And people with lived experience were asking that the Safe Space Hub was away from an ED and not on hospital grounds. If it had to be on hospital grounds, that a new building would be required that doesn't look like a hospital. That it should be walking distance from the hospital in case there's a need for medical attention. And then some suggestions in terms of very specifically in the Redcliffe area, that it could be near the library or art centre to connect with other parts of the community. That other location ideas included within a shopping centre, in an arcade near the jetty, the showground area, neighbourhood centre, in the GP super clinic, near the Botanical Gardens, near Centrelink, Red Cross Centre or Bluewater Square. Now, I do just want to raise that we have had additional information provided with regards to the space near the jetty in Redcliffe, and that it's a very traumatic space for Indigenous people. It has historically a lot of trauma associated with it, so that area is not appropriate. So I just want to acknowledge that we have heard that. That the safe space also should be an independent area, not associated with the hospital, and that it could be a residential house. So from a health professional standpoint, they did have a few concerns about it being an actual residential house because of the fact that there's such a high level of need for housing in Redcliffe, and would it be appropriate for a service to take potentially a house that somebody could be living in. Excuse me. They agreed that it shouldn't be on hospital grounds, that it needed to be close to hospital for easy access if needed, that it ought to be warm, inviting and central, close to public transport, located near other services to facilitate easy connections. And there's just that there should be some extra consideration around the location because of the homeless population. And one of their ideas had been the showgrounds as well. Thanks, James.
So what we're looking at now is the inward connections. In particular, what we can see in the far left column is that the needs are this sense of feeling welcome. From a blue sky dream perspective, what we can see there is alignment with both the health professionals and those with lived experience of suicide. So the ambulance and police can drop people off. Peer workers can go to ED and pick individuals up. Carers, family support workers can all bring people in and stay with them if wanted. A pathway in from the emergency department if the person has gone there first. Pardon me, and process to determine safety of other guests. From the health professionals' point of view, and comments came forward that the pathways from the hospital to the ED was agreed to, that the ED triage is able to help someone to get to the safe space. One of the areas that still needs a little bit of conversation and thought into what the current rules are is the pathways from the ambulance and the police determine how that might happen. And of course, a no wrong door approach, but concerns around safety of the other guests.
So when we looked at outward connections, the needs that were identified from the people with lived experience is that to feel that there's something in place, so I'm not going back to exact same position or feeling worse afterwards. Having a plan, getting some sort of direction for the future, practical referrals, collaborative planning, information and resources, such as phone numbers, appointments, continuity, follow-up to make sure that the connection was actually helpful, and help with practical things like signing up for Centrelink or finding a doctor. From their group session, from a blue sky dreaming perspective, consultation with community groups so that peer workers are well informed to be able to refer and link people with appropriate services. And perhaps the safe space could have a community directory that's kept up to date. Resources for people to get information on mental health and suicide prevention services. Someone can bring guests to the hospital if they need or want to go. Closely connected with other services, and know whether they have the capacity to take people on current knowledge and good relationships. So just really talking to those strong connections to make sure that you're not connecting someone with a service that does not have capacity to see them. That follow-up via a phone call a day or two later would be good. It's important that people leave with extra information and able to refer to services for relationship issues, financial issues, chronic pain, emotional pain, grief. So acknowledging that there can be all sorts of underlying contributing factors to someone's distress, and that a safe space is able to make direct contact with ED. The health professionals spoke about the safe space having close connections with other services as well, that formal partnerships with other services would be developed, that a network coordinator maintains a group that will have close ties with safe space. Guests are able to call mental health line for additional support from a private area within the safe space, and that there's a pathway to hospital for guests who need that stepped up care. So lots of alignment there between all stakeholders.
And there also may be more that come through, more ideas, certainly from the survey. So encourage everybody, if they want other ideas in there, please do so. We can work through those. So in terms of the service model here, we can see the needs on the left-hand column: to be believed, a sense of being believed, a feeling of self-worth, to be cared for, and encouragement, a validation and to be taken seriously, to be seen quickly, reassurance, and a preservation of dignity. From a blue sky dreaming perspective, some comments that came through were: don't have to fill in the forms on arrival, and information will be gathered informally through a conversation, having some non-binary options as well, some level of information needed for safety. Enough peer workers to do a warm welcome on arrival, offered amenities like tea and water and coffee as such, individual care and choice for the guests, speak to someone straight away, an assessment if they want. One area we can see there in orange and still need to kind of work through is this idea of the communal elements, in particular, this concept of a barbecue on a Saturday night and group sessions. If I quickly whip to the other side there on the health professionals, the concern that we have there from health professionals is around that group or social elements maybe causing to distress other guests in that space. And communal elements exist but are not held in the space or itself. So back to the blue sky dreaming in the green section, appointments available for people who want to speak to someone at a specific time, an outreach component available. We still need to get some agreement on no time limit for guests in the safe space, but agreement aligned with tactile activities available there: TV, movies, magazines, sensory items, colouring books and such. Carers are welcome. Voluntary feedback through some form of QR code when departing a safe space, and don't have to do a safety plan. From a health professionals' perspective, we got agreement on the outreach component. Guests have an option for safe space to collect and keep information about them. So if they do return, the peer workers can have a level of information relating to their story. As I mentioned, some concerns there around the communal elements. Agreement on considerations for children in the safe space. Some work still need to be done around concerns about this time limit. Therapeutic support offered as an option as well, and what that might look like still needs to be fleshed out. But the flexibility to meet all individual needs was agreed to.
Lovely. All right, so staffing and workforce. Needs identified by people with lived experience of suicide: someone to check in regularly with you when you're in the safe space, to not be left alone; connection with someone to reassure you that things will be okay; to speak with someone with a lived experience of suicide; a peer worker who can use skills and training to quickly build rapport; and someone who really understands. In terms of the blue sky dreaming, a diverse peer workforce with wide array of experiences and skills; enough staff to manage busy nights; staff are trained in mental health first aid, cultural competency, working with youth; that it's purely peer-led; that peer workers are supported and have knowledge to direct people to specific services; that staff have a dedicated time to do follow-up calls while the space is closed and no one's coming in; and close connections with other services. In orange here, may need clinician on staff, but they should have lived experience. And I guess from a health professional perspective, there was concerns about being able to find enough staff who meet the criteria if it's just purely led, and also that a multidisciplinary team could be really advantageous in the space. So some more discussion and looking for more input through the survey with regards to that actual staffing model. In terms of volunteer network to help extend the hours, some health professionals were concerned about using volunteers, but in other areas, staff are comfortable sitting with guests in their distress. Staff are trained in mental health first aid, basic DBT skills and therapeutic interventions, and that ideally entire staff is well-trained peer workers. Entire team is trained so everyone is delivering the same practice. So I think just in terms of further discussion needed, it's around the makeup of the actual staff model and whether a volunteer network to help extend hours is something that this area is looking to do or not. So we'll be really interested to get some more input there.
Thanks, Bonnie. In terms of the physical environment, what we'll see here is a bit of kind of crossover from some of the other things that we've touched on briefly. So in terms of the needs, the physical safety and the space where I can just take a breath and regroup, a calm, quiet environment, option for some privacy, calm and open space, and soft and quiet. From blue sky dreaming point of view, this idea of lots of plants, open communal spaces, an area for privacy. I'll just go through the green things first where we've got a line, and then I'll come back to some of the orange. Areas for children, space, a residential house that does not look clinical or feel administrative. Separate sensory rooms, kitchen where you can make amenities, sturdy and comfortable furniture, outdoor space with barbecue facilities and a separate smoking area, soft colours, furnishings and non-gender bathrooms. From a health professional, what we've got agreement on is it does not appear a clinical space. So areas we need to kind of build on is this idea of section with beds where people can rest, and some of the concerns there are about, from the health professional's point of view, people accessing beds who aren't actually experiencing a suicidal crisis, but it might be aligned to some of the homelessness in the Redcliffe area. So that's an area we kind of really need to kind of explore a bit further as to how and what that looks like. This sense of being able to move furniture and privacy screens around and change the space according to the needs. And the concerns come from a safety point of view around shifting heavy furniture. Obviously would need to be considered how that and what that would look like. Other areas that are going to need a bit of support in unpacking is mixed opinions on the residential house and also concerns, as we've mentioned earlier, about this sense of responsibilities for kitchen and the barbecue area. So a few things we still need to kind of map out in terms of physical environment.
Thanks, James. And I think through the survey, it would be really good to just get some more insight in terms of that physical environment, how the layout might could be arranged to satisfy various needs of different people as well. So I guess some more sort of deep thinking around the physical environment would be really helpful. From an accessibility standpoint, people are expressing needs of information about where to get a drink, where the toilets are, just so that they can navigate the space, to feel really welcome and to know what to expect. So some information that is actually out in community so that people actually know what to expect when they walk in the door of the safe space. From a blue sky dreaming perspective, ideally 24/7. We do realise that there's not going to be the funding envelope to start with for a 24/7 service. And so with that in mind, the blue sky was then that it would be late evenings or overnight, weekends and weekend nights, preferably on the ground floor. But if it's not, just to make sure that there's a lift there to make it completely accessible. Plenty of parking, taxi vouchers available for people to be able to come to the safe space or to get home. Close to public transport, privacy so that people feel comfortable to speak freely without fear of judgment. Contemporary environment, branding to help normalise it, reduce stigma and present the safe space as an innovative place and not associated with ED. A warm and welcoming space for everyone while maintaining safety, that people can stay as long as they need, that it's culturally accessible and that it's physically accessible for people with disabilities. Health professionals and stakeholders, they're in agreement with regards to just signage to let people know that they're in the right spot, that it's open extended hours on weekends and ideally open 7 days a week. There were some concerns, however, about funding for taxi vouchers, so just needs to be considered in terms of budgeting. Some sort of transport offered to guests, so is there some way of having a connection in community where you can tap into some community bus or something that can help pick people up, and that there are protocols for guests who are using the space when they don't need it. So next steps. So this feedback loop and survey, and the webinar will be released this afternoon. And we really, really need you to circulate the survey and the webinar to as many people as you can in your networks. We really, really want to hear from a lot of people in this community about what they want and what's going to meet their needs. So the survey will remain open until the 26th of October. 2 days after that, we'll all come together for a combined session with people with lived experience of suicide and health professionals and other stakeholders. And that session will be done on the 28th of October. And then on the 4th of November, there'll be a final feedback loop, which will be another webinar and a survey. So that's all from us. Please take part in the survey. If you've been a part of the sessions, please still look at the survey, sense check it, make sure we've got it right. You may well have had further thoughts since those sessions, and you can add any additional ideas into that survey and then share it with your networks. So thanks so much, and we will see you soon.
Thanks, Bronnie. Thank you, everyone.
Thanks, James.